so much for that introduction. I wanted to thank the organizers for an opportunity to tell you a little bit about our work at the NIH. Just to give you, just very quickly, you heard a lot about my background. This all kind of stems from when I was a fellow at Mount Sinai, when observing that the patients with different inborn areas of metabolism, when they would get sick with simple coughs and colds and stuff, which for us would not be problematic, turn out to be particularly problematic for kids with inborn errors. So based on that, I designed a research program to look at that question specifically. So I'm what you would call a physician scientist. I know Dr. Vockley today has talked a lot about, and yesterday, about areas of expertise and focusing in on something. And basically, what I focus in on is host-pathogen interactions. So in other words, even though I am trained in clinical genetics and biochemical genetics, et cetera, I'm not the person to make dietary recommendations and things like that. Although the PB2 is pretty awesome, I have to say, I've tried it myself. So at NIH, you have to realize it's a research hospital that is sponsored by your tax dollars and is in Bethesda, Maryland, and every single person who comes there comes on a research protocol. So there's a question that's being asked specifically about their disease. So as a physician scientist, that's what I do. So I lead something called the MINI section, which stands for the Metabolism, Infection, and Immunity section. And our goal is to define the risk factors and mechanisms that are involved in host-pathogen interactions. So what do I mean by host-pathogen interactions? I mean basically viruses and how they interact with their host, or people, in the setting of inborn areas of metabolism, specifically mitochondrial disease. So, a lot of the stuff I'm going to talk about today, I know I talk specifically about mitochondrial disease, but a lot of the stuff that you'll see is generally applicable to a lot of the different inborn areas of metabolism, including fatty acid oxidation defects. There are a lot of similarities between FAODs and mitochondrial disease in terms of some of the metabolic disturbances that they experience. So a lot of what I'm going to show you today is pretty translatable. Okay, so why do we care about host-pathogen interactions or infections in mitochondrial disease? Well, it turns out that sepsis and pneumonia are actually two of the most common causes of death in this population. Sepsis is one of the top admitting diagnoses to hospital. A couple years ago, we looked at a cohort of patients with mitochondrial disease, and this was about 26 patients or so, and it turned out that 80% of them experienced recurrent infections, and a lot of these infections are respiratory. So the respiratory viruses that we all experience, throughout the year. Intercurrent infection, or basically any type of infection, particularly viral infections, are a leading cause of neurodegeneration in these kids. So there are certain types of mitochondrial disease where they actually form certain areas of neuronal death in their brain, and when they get viral infections, they are at risk for developing these lesions in their brain. So as you can imagine, the families are very much aware when flu season comes around. They take certain precautions in terms of that. And this is even outside of the current COVID-19 pandemic. So the COVID-19 pandemic, when it arose about 2 years ago, really presented a challenge to the IAM community in general, and especially for the patients that I follow, the kids with mitochondrial disease. It's a palpable threat to these families because of what can happen to their child. Okay, so I'm sure a lot of you are familiar with the term metabolic decompensation. For FAODs, it can mean things like rhabdo, it can mean things like hypoglycemia, liver dysfunction, et cetera. In mitochondrial disease, a lot of the similar things, right? So these can be life-threatening situations where you have issues with bioenergetic failure. They can develop lactic acidosis and disease progression, including organ failure. They can develop encephalopathy. Those areas of neuronal death that I spoke about, that's what we call metabolic strokes. They're not strokes in the vascular term, but it's more about death of certain areas in the brain. And a lot of times the patients are left with long-term complications after these episodes of infection. They can be basically simple infections. You can wind up in the ICU like I'm showing you here, and this can be the level of care that these kids can require when they have these infections. The treatments, unfortunately, are quite limited for kids with mitochondrial disease. So we have to find new ways or understand, what What is this interaction between the virus and its host that are making things go so horribly awry? So therefore, one of our goals is basically to keep patients healthy. Okay, so I'm just going to recap very briefly about what we've all been experiencing for the past 2.5 years. So this was the initial timeline for COVID-19, where back in around December of 2019, the World Health Organization basically issued an alert that there was a new virus out and it was of concern. And then that brings us to January when they actually identified it as SARS-CoV-2, so related to other coronaviruses in the past, but this was a new coronavirus. By March 11th, so this is only a couple months later, there were over 100,000 cases and more than 4,000 deaths in 114 countries. By April 2nd, the number of cases topped 1 million worldwide. And then by about a week later, essentially, the global deaths due to COVID topped 100,000. So this was a rapidly kind of moving pandemic, as we all know, and how we all experienced. And this was something that the mitochondrial disease community and the IAM community in general was very concerned about. So we had to move quickly to kind of understand, and we had to retool. So basically, I see patients in the NIH Clinical Center. We fly them in from all over the country, we evaluate them there, we look at various aspects of their immune system, how it functions, what viral infections they may have been exposed to. Well, during the pandemic, nobody wanted to travel, right? Because it was a risk for them to travel. So we had to come up with other ways of how to assess patients and what was going on during the COVID-19 pandemic. And I'm going to tell you about some of those studies today. Okay, so this was back in June 15, 2020, 7.9 million cases worldwide, 400,000 global deaths. This was as of last Thursday. What's the big difference? There's that green splotch down there in the right corner, right? That's vaccination. So vaccination, basically it was around December of 2020, December of 2020 when it first started to become available and has made a big difference in terms of the pandemic itself. Okay, so how did we seek to address, the different aspects of the pandemic when our patients were not willing to travel and we wanted to figure out what was going on and any recommendations that we could make? So one of the things that we did is we actually issued questionnaires online to our patients to figure out what they were doing, what they were experiencing, what was going on. So we did that in April of 2020, and then we also did it in June of 2020. Then we also launched a study where we looked at where parents would report to us when their children became ill, what were they experiencing? Were they diagnosed with COVID, and what were they actually experiencing, and what were the outcomes of those infections? And I'll show you some of the data. Then we started to look at essentially vaccination, which is something that we're continuing to look at, but we also started to look at other viruses, right? So you probably heard during the pandemic, oh, we're not seeing much flu anymore, right? Because everyone's staying home. Or RSV seems to have shifted in time. RSV, it's a certain time of the year, and now we're not seeing it as much. It turns out all the infections are still there, or were still there. They were just shifted in time, essentially, because of some of the behaviors that the public was undertaking as a result. Okay, so all of this happens under a study that we have at the NIH Clinical Center, which is called the MINI study, which stands for Metabolism, Infection, and Immunity Study. And we want to understand why kids with mitochondrial disease decline during infection, right? The ultimate post-pathogen interaction, and we want to improve their well-being. So to do that, we invite people, usually, as I said, outside of the pandemic, to the NIH, and this is the NIH Clinical Center right here on your right. And this is a natural history study of infection and immunity in these kids with mitochondrial disease, where we look at their infection history. What have they been infected with in the past? What do their antibody profiles tell us? How does their immune system function? Can they properly mount an immune response to infection? And then also, if they've had infections, what kind of disability have they developed as a result of those infections? Okay, so the first thing is understanding the experience of the mitochondrial disease community during the COVID-19 pandemic. And this was something that we did via questionnaires. So these were questionnaires that we blasted the mitochondrial community with to find out what was going on. This did not, even though I'm a pediatrician, I primarily take care of children, this questionnaire was directed at everyone. So it was directed at adults as well as children. So as I mentioned, there were 2 time points where we did this. We did it in April of 2020 and June of 2020 at the kind of beginning of the pandemic as it was really kind of ramping up. We got 688 responses. Most people completed the questionnaire, which we're very thankful for. And a lot of the diagnoses were, what we call mitochondrial disease not otherwise specified, where they don't kind of fall into these classical categories or acronyms that we have for certain mitochondrial diseases. About 62% of them had a known pathogenic variant, so they had sequencing and they identified a pathogenic variant. During that time, so this was April and June, there were about 5 positive cases of COVID that people knew about. Of course, testing wasn't as widespread at that point as well, but these were 5 individuals. And at the same time, 68 individuals actually requested a test, and 14 of them were unable to receive testing at the time, right? So look how far we've gone now, right? We have tests in our homes that we can do. I did one before I came here. I did, so we've progressed a lot in terms of our ability to try and manage and live with this pandemic. So what were some of the symptoms? Most commonly, we see things like fever, a new cough, shortness of breath, and there were a few cases of pneumonia. So this was early in the pandemic, April, June of 2020. Risk factors for exposure. So this was important because some of these were potentially modifiable by the community, one of which was exposure in healthcare settings. So, visiting your doctor's office, now they have you sitting, a certain distance from people in the doctor's office. They request that you wear masks. What we found in that particular community is about 55% were still going to doctor's visits, about 14% were still going to the ED. For reasons that they had to, and 12% were still hospitalized. With regards to, public contact, 38% of our families that we looked at had a household member who was an essential worker, right? So that, of course, potentially brings, by the fact that for their work they have to go out and face the public, right? This is a risk factor for bringing it back into the house. And we wanted to study that, and I'll tell you about some serologic studies we did later with regards to that. 12% of adult patients were actually essential workers. So almost 40% overall had at least one person in the house, and about 12% of the adults that we looked at were essential workers. So these are risk factors for bringing the infection into the house. And not just COVID, any kind of infection. So kids with mitochondrial disease also have other risk factors, as do other inborn errors of metabolism, right? So not only do they have their disorder that they are dealing with, but they can have, which comes with it things like, they may have access, they may have certain devices, they may have trouble with swallowing, breathing, things like that. But they also can have other comorbidities, like asthma, right? Asthma was a risk factor for adverse outcomes in COVID. A lot of our patients do have respiratory muscle weakness. A lot of our patients reported immunodeficiency, and then asthma I mentioned. Overall, about 73% of the patients that we looked at reported at least one condition that was considered a risk factor for COVID, for adverse outcomes during COVID. So those are things that we have to think about as a community as well, is that our kids have other stuff too, right? Asthma has been on the rise for decades now, and I'm sure there are some people in the room who have kids who have asthma, right? Or some form of reactive airway disease. So these are things that we have to think about too in terms of managing our children during illness. Okay, when we asked our families, what's your greatest concern about COVID-19? This is probably not a surprising answer. Lee syndrome is a type of mitochondrial disease where they have this targeted neuronal death in the brain. And so they were concerned, this is just one quote of many, which basically says that they were concerned that after getting COVID-19, they require hospitalization, they experience a metabolic crisis and lose their developmental skills, because that's kind of the normal course of things when some of these kids with Lee syndrome get a virus. So, the CDC recommended all these different behaviors, right? That non-pharmacologic behaviors or interventions that you could try to try and prevent the spread. right? So one of them was, wearing a cloth mask, staying 6 feet away from people. Hand washing was one of the first ones, right, that came in that people were doing. People were ordering groceries online. They were, basically staying in their homes. A lot of people were teleworking. So these are what are called risk mitigation behaviors, right? And the CDC were responsible for recommending these. It turns out that, in general, the inborn error of metabolism community, even before the COVID-19 pandemic, are really good at these things, right? Because they know when flu season comes around, there are certain kids, and it's not every kid, but there are certain kids who have difficulty with infection, so the families are very aware of this. So when this came along, they're just like, no problem, I got this. So we asked the families, what are you doing? What do you actually do? So we divided our risk mitigation behaviors into social, which are the green ones, and that includes things like, canceling gatherings or canceling travel or, not going to restaurants or things like that, social things that you would avoid. The next one was shopping, right? So ordering in your groceries, having stuff delivered, stockpiling medications, things that you would do to avoid public contact. And then the last thing was hygiene, which were things like, being masked inside the home, outside the home, hand washing, things like that. So a lot of, you can just looking at the bars, for those 3 different categories, adherence to some of those things was pretty high, right? And it tended to depend on convenience for the individual, whether they actually adhered to that behavior or not. But in general, when you look on the right, the families usually engaged in about 10 or 11 risk mitigation behaviors. And that's on the high end of what the general public actually does. The general public was not doing 10 or 11. So once again, this community, we know what we need to do in this situation. So, okay, so these are all questionnaires. We've asked people kind of what they experience, but what's actually going on? How many kids out there actually have COVID or asymptomatic COVID? So we did a viral study in the household of families with a child affected with mitochondrial disease. And the way we did that is we used this microsampling platform called Neoterix. So you can see that on the right, that's the little Neoterix unit. It's like a clamshell that opens up. And inside there are 2, they're almost like Q-tips. And we would send lancets to the family where they would prick their finger, and then they would soak it up with this little Q-tip, and then close the clamshell and send it back to us. So from that, we can actually pull antibodies from that blood and determine COVID-19 exposure, and then, as I will show you later, other viral exposures. So what was the family actually exposed to during that time? Okay, so the first study is the SARS-CoV-2 antibody status in households with children with mitochondrial disease. So the way we designed this study is based on this idea that the household, or members of the household, because they had to go to work, because they had to have contact with the public, some were essential workers, that there could be what are called secondary attack rates, right? So in other words, they could bring it back into the house, and other people could get that infection, whether it's COVID or it's something else. So this was a meta-analysis. Meta-analysis is just a fancy word of taking a whole bunch of studies and putting them together and seeing if you can come out with a message from that, a common message from all these studies that you kind of pulled together. So in a meta-analysis of 54 different studies, they basically found the secondary attack rate. In other words, someone bringing it from the outside and bringing it into the house was about almost 17% or so. So not insignificant. So we decided to look at the different types of antibodies that you can look at for SARS-CoV-2. So we looked at the nucleocapsid, which is part of the virus, which covers the outside. We looked at the spike protein. I'm sure everyone's heard of the spike protein by now. And then a part of the spike protein called the receptor binding domain. So just to remind you, the way antibodies work is that you get exposed to something, and this could be a vaccination, or in this particular case, a virus, and you develop, the immune system, B cells, develop antibodies. They're supposed to be protective for you. So the first type of antibody that you produce is IgM, And then eventually that switches over to IgG. And IgG lasts, decades. Depending on what the virus is or depending on what the vaccine is, it can last for decades. Just to give you an example, measles, right? Almost everyone in the room, I imagine, is vaccinated for measles. Does anybody have any idea what the half-life, meaning the amount of time it takes half of your measles type, antibodies to go away, how long that is? So it's calculated because it's 500 years. So in other words, when they look at individuals who have been vaccinated for measles and look at the decay of the antibodies, it's like 500 years that measles would last you. So, as aging improves in this country, just rest assured you're protected from measles. Okay. All right, so this is what we found. So we sampled in 2020 and 2021 in this population. So remember, we're looking at family members and we're looking at the kids with mitochondrial disease. So this is 20 families and 22 kids with mitochondrial disease. So 2 families had 2 kids. And so in A, what we're looking at, that's something called a heat map. So what am I measuring? I'm essentially measuring who's positive, essentially, based on the amount of antibody that they've had for being exposed to SARS-CoV-2. And the more yellow it is, the more positive you are, okay? So looking between 2020 and 2021, we did have positive cases in 2020. In fact, in 2020, nearly every family, 20 out of the 22 families in 2020, that's like a tongue twister, had at least one individual who was exposed to SARS-CoV-2, who had antibodies against SARS-CoV-2. In 2022, that number was pretty much the same. It's just that the amount of antibodies were so much higher. So there was something different about their exposure from 2020 to 2021. So people were getting exposed at both time points. It turns out in 2020, there were only a few people who actually got sick. In 2021, there were a lot more people that got sick. So once again, something different about the exposure that they received. And right next to it, those are line graphs connecting essentially the 2020 and 2021 levels of antibodies. And you can see they all essentially go up, right? So people are having higher antibody responses in 2021 than they did versus 2020. And more people are getting sick versus 2020. When you split it out by mitochondrial disease versus the other family members, it essentially looks the same. Both of them were seeing increases in the amount of antibodies indicating exposure to SARS-CoV-2. So it was essentially everywhere, right? The first year, so how would I kind of summarize? The first year in 2020, there were a lot of exposures. They were less robust exposures, so therefore less people were sick. There were a lot of asymptomatic cases. By 2021, with the persistence of the virus and probably pandemic fatigue and becoming tired with all the different risk mitigation behaviors that people would employ, because we're human, right? That led to more exposures and actually more illness and higher levels of antibodies. Okay, so the antibodies that I showed you are what are called binding antibodies. All they tell you is whether someone's exposed or not. It doesn't tell you whether those antibodies are any good at preventing illness. That's what neutralizing antibodies are, right? These are antibodies that actually neutralize or prevent you, or prevent the virus essentially from binding and entering the cell and replicating and, basically making someone ill. So the next thing we did is we looked at neutralizing antibodies. So you can see that in 2020, actually it's kind of small. Is this a pointer? No. Okay. Does it work?
No.
It's not a pointer. Okay, thank you. So basically on the upper part there, we have mitochondrial disease, kids in red, we have family members in blue, and to the left is 2020, to the right is 2021. So basically you see a line connecting 2 dots between the 2 years. And here's the basic gist of it. In 2020, very few people had neutralizing antibodies. They were exposed, but they did not develop neutralizing antibodies. By 2021, we had more individuals who actually developed neutralizing antibodies, whether they were with mitochondrial disease or a family member. And that was for two reasons. One reason, as you can imagine, was vaccination, right? So vaccination was becoming much more widespread by that point. But the other reason for neutralizing antibodies is we had a significant number of people who actually were getting infected again. So some of the antibodies that we measure, I said we measure nucleocapsid, we measure spike, and we measure receptor binding domain. Nucleocapsid is not in the vaccine. So therefore, if you detect nucleocapsid, that actually detects exposure to the virus. So we were finding both things. We were finding a contribution from the vaccine, but there was also a contribution from getting infected because the pandemic was persisting. And infection, unfortunately, here's the summary of my talk. Infection is inevitable. We can do some things to try and keep it from happening, but in the end, it's actually pretty inevitable. Okay, so these are our families, and this is what they looked like from 2020 to 2021. Basically, if a family had two collections, one in 2020, one in 2021, they're connected by an arrow, okay? Red equals positive, green equals negative, and blue are people who chose not to participate. Basically, there's a lot of red on there. Right? And this takes into account whether they are vaccinated or not. So when I say positive, it means they had COVID. Okay? There's a lot of red there. Basically, viral infection is pretty unavoidable. Okay. So next we wanted to look at our household viral exposure in children with mitochondrial disease. So we wanted to move. Because what we had heard, or what you probably heard this in the news, is that these risk mitigation behaviors were changing other viruses, right? They were changing RSV, they were changing, flu season, all these other things. So we wanted to look at other viruses. So we did our sampling the same exact way, and from the same samples, to be perfectly honest. And we used a platform called VirScan. So VirScan is a way of detecting any viruses that you may have been exposed to in a drop of blood. And so, once again, what we're relying on, essentially, is the antibodies against the different viruses to tell us the story. It's kind of like a CSI investigation, right? Where there's a crime that's been committed in the past, and you're looking for clues, and there are fingerprints or whatever, and these fingerprints are the antibody profiles. So it will tell you, essentially, what you've been exposed to. So, this is a really popular platform that's used to look at all different types of, populations and to see what viruses they've been exposed to, and et cetera. So it's a really, really good platform, a robust, strong platform. So this is essentially what we found. So these are, there were 15 families who participated in this study, and basically what we found is that people were exposed to multiple things, right, over the year. It included things like Enterovirus B, respiratory syncytial virus, influenza, rhinovirus, basically what you would expect. And this is over 1 year's time. The average family member is exposed to 2 viruses over a year. The average kid with mitochondrial disease, 5. Okay? So 5 opportunities to potentially have something bad happen. So we next looked at what are the top hits? What's the hit list for these viruses? And this is it. So Enterovirus B happens during spring/summertime. You get things like, Enterovirus B encompasses a pretty large family of different viruses. So you can get things like GI symptoms, like acute gastroenteritis, diarrhea, stuff like that. Or you can get respiratory stuff. Rhinovirus A, that's one of the common cold viruses, right? That one was pretty common. Enterovirus C is once again another GI bug, rhinovirus B, Enterovirus A, influenza, respiratory syncytial virus. The most common one was Enterovirus B. And not only was Enterovirus B the most common virus, but it was the most commonly shared virus within the family. And the thing to point out about that is the way that Enterovirus B is transmitted is by contact with things that are infected from other individuals. So it could be glasses, spoons, silverware, stuff like that. Okay, so this is incredibly small, so I'm just going to summarize. what happened to these kids with all these different viruses that they got? You know, what was their clinical outcome? Did they visit the hospital? Did they visit the emergency room? So out of the 17 kids that we followed for this, you know, what viruses do you have besides COVID? It turns out that 6 of them were hospitalized. So that's 6 out of 17. There were 3 ICU visits, and there were 2 episodes of worsening of disease. So in other words, one patient developed increased frequency of their seizures, the other person had new onset seizures. So these, you know, associated with these illnesses, these viral illnesses. What was interesting is that when we look at, you can use a rating scale to see how bad their mitochondrial disease is. It's called the IPMDS, the International Pediatric Mitochondrial Disease Scale. And the kids who tended to have worse MDS scores were more likely to be hospitalized, right? And that kind of makes sense, right? Because their disease kind of puts them at risk to begin with, and if they have worse disease, they're actually more likely to be hospitalized or have complications from having a viral infection. Okay, so takeaway messages. The risk mitigation behaviors that we saw can be effective, and that's what we saw early in the pandemic in 2020. So these things like, you know, the social ones, not going out to restaurants, the hand washing, the mask wearing, all these other things can be helpful. However, viral infection is inevitable in mitochondrial disease, regardless. So we have to figure out kind of new ways to approach this problem or learn how to take care of children during these episodes. And therefore, it's important to understand these post-pathogen interactions, and we'll continue to conduct studies like this. So we're continuing to follow these kids into the future, and we basically sample them every 6 months or so with these kits that we send to their homes to see what viral infections they were exposed to and what was the outcome. What we don't know at this point is, does this occur? It doesn't occur with every single viral infection, okay? So not every viral infection makes a kid wind up in the hospital in the ICU. So the questions we're starting to ask are they specific viral infections that do this? So it's not everyone, it's specific ones. And we do this by our continued surveillance of our population. Thank you very much. I appreciate your time. This is my group here at NIH and a QR code for anyone who is interested. And I'll take any questions.
All right, questions for anyone? Nobody? Okay, what?
Any questions?
Okay, go ahead.
Hey, Peter, thanks for coming to Pittsburgh. Really appreciate it. What kind of topic? Is there any evidence or any concern about using any of the antivirals, any of the anti-COVID viral medications that are out there now in our fatty acid oxidation kits?
Yeah, so I don't know if I have the answer for that. I mean, so the book, at least for mitochondrial disease, there is a book that basically talks about the drugs with mitochondrial toxicity. It's about that thick. It's the brown book that everyone has. There is some concern in general, I think, with some of the antivirals with mitochondrial transcription, right? But I don't know the answer of whether that produces potentially problems for fatty acid oxidation. Although the two disorders are so much aligned, I would imagine, you know, a drug that potentially can inhibit. So mitochondrial transcription is a function of the mitochondria for it to, you know, function normally. So since fatty acid oxidation, you know, occurs in the mitochondria, is important to feed into the respiratory chain, I am not surprised that, you know, it could potentially, but I don't know of any specific reports or anything like that.
What is your opinion of the papers that cite the observation that asthma is protective in COVID and the outcomes are less severe? And did you look at that in your population? Was asthma protective against COVID?
Yeah, so I've seen those papers, but then of course there are papers that say the opposite. So that information, they're still trying to weigh that information in terms of, you know, what role asthma does actually play in this. In our population, I didn't show the data, but for the ones I showed for our serology studies for COVID and for all these other viruses, I think it was like, I want to say 20% had asthma, actually. The one patient I'm thinking of had RSV infection who deteriorated, but did not have a flare of their asthma during that particular episode. So our cohort's pretty small, so it's hard to make gross generalizations. We didn't really see it, but in general, those data are being weighed between, because there are papers about the protective aspects and there are papers about and you also hear the same thing, in pediatrics in general. There are, kids do really well because they don't express the ACE receptor and they don't, and then you hear other things. So it's a matter of kind of assimilating all the data together, which I think we're still, as a community, still in the process of doing that.
So this kind of goes back to, and probably both will have input on this with the like Paxlovid and stuff for the kids in the FEOD, but I was just curious because of the effects, like it gives warning about your liver, and we know like the liver in our FEODs is important and compromised. Like how would you like hypothesize like the effects of the liver, or is that a valid concern? Like if we were thinking about an antiviral when they get COVID?
Yeah, I mean, I think you can, but I think it's hard to recommend treatments based on hypotheses, right? I mean, it is, it's difficult. And if you think about it too, if you were to look in a PDR, right, physician's desk reference, any drug that you pull up would pull up something that you'd be like, I'm gonna think twice about taking that because they report every single, potential outcome or reported outcome, adverse outcome with that drug. So it's risk-benefit ratio, right? That's what you're judging at that point. There's also monoclonal antibody therapy as well. It's not just the antiviral, right? So that's another potential, for kids, and those are generally reserved for kids who are at risk for having really adverse outcomes with COVID. I say kids, sorry, it's for everyone, but I say kids because that's what I deal with.
Yeah, and I agree with the caution about theoretical concerns. I asked my question in a very specific way. Is there any evidence?
Right.
And so if the answer is there's no evidence, then you have to fall back to first principles. If a medication treats an illness, and that illness has significant ramifications on your primary disease, then you use the treatment. And so I have treated patients with fatty acid oxidation disorders with antivirals, monoclonal antibodies, and whatever was available at the time during the pandemic. Because otherwise you just paralyze yourself. It was the same question with vaccination. Should we do vaccination? Well, we know vaccination originally was maybe a little more protective, but it was at least protective against severe outcomes. And so any concern about a high fever related to an immunization, well, that's self-limited. You see it in 12 hours. It's gone by 24 or 36 hours, and then you have protection against an ongoing systemic onslaught of virus. So yes, I recommend it and have vaccinated all of my metabolic kids for COVID. So.
Yeah. And we've actually looked at that, Dr. Broccoli. We've looked at the VAERS reporting system as well as done a survey ourselves. And in general, I should say for the mitochondrial disease community, the reactions that they're having are within the normal scope of, with limited exception, they are generally in the normal scope of what I experienced when I got mine, the soreness, headache, some fever for a day or something.
What is the difference between the immune response to measles, which lasts 500 years, and COVID, which lasts 3 months? Do you not make IgG against COVID? Or?
No, you do. It just doesn't last that long, right? So we don't understand completely yet what leads you to have these kind of very long responses, very, very short responses. So another example would be parainfluenza virus, right? That's another one that you don't really maintain antibodies for that long. So it may have to do with the strength of the stimulus that it actually gives to the immune system, that it just doesn't make the other, one of the other hypotheses that have been floating around for decades is that the immune system retains some type of imitation of the antigen, in other words, the viral antigen, so that the B cells can continue to see it over and over again, right? And therefore get stimulated and be maintained a long period of time. The other difference too with measles is it's whole inactivated measles, right? So you're getting a lot of different epitopes in that measles versus COVID, which are essentially based off the spike protein. So you're either getting receptor binding domain or spike. So there may be a lot of things there involved, and I don't think we really know what the answer is yet. But yeah, the 500 years, I love quoting that because it's like, obviously we don't live 500 years, so. And by the way, varicella, you know, what's varicella? What's the half-life of varicella? It's almost like 40 years, 35, 40 years. So, you know, do for my varicella.
Thanks, Dr. Hill. I have a couple questions that came in from our virtual listeners.
Yes.
First question is, are you seeing persistent symptoms of coughing that require follow-up after COVID infections? And kind of what's your recommendation for patients who are managing that?
Yeah, so it's funny because that does not only occur as a result of COVID. It actually can occur as a result of any kind of upper respiratory viral infection. And part of it is because, you know, the way that viruses, especially respiratory viruses, can infect your respiratory passages or the epithelial cells lining your respiratory passages or your lungs, is that it can be it can be a little destructive and very irritating. So even after the virus is cleared, you can continue to cough for like weeks. So, you know, it's a matter of caring for the cough itself, even though the virus may be gone. And you can do things, I mean, there are antitussives and things like that, and, you know, kind of cough drops to help soothe, you know, kind of area, cold drinks, all sorts of things that your general pediatrician would recommend. But it's not, the interesting thing is that that's not specific to COVID, actually. That can happen with any type of respiratory viral infection.
Thank you for that. Next question is, this is a patient from Europe that's asking this question. And he's asking, what's your opinion about the booster? I received 2 doses after that. I got infected with COVID, and now I'm not sure what to do. I'm from Europe, and it's difficult for me to find information related to the effects of the booster on CPT2.
Yeah, so I can speak specifically to the booster itself, where I think it's the Israeli study that they found where if an individual actually had COVID and received the booster, the 2 effects were actually kind of additive. Like it actually, you know, it increased the titers of antibodies, protective antibodies. So there was an additive effect between the 2. For CPT2, I can't comment specifically. I don't know if Dr. Vockley has any feelings about it, but I don't see these patients. That's why I'm asking specifically.
You know, my same answer as before. We don't have any reason to believe that fatty acid oxidation patients are responding any differently to the vaccine than other individuals. We know that there's at least some inflammatory component to COVID infection, SARS-CoV-2, and that we're now seeing increased inflammatory state in our fatty acid oxidation patients, and so all of that to me adds up to whatever protection you can get, you should take it. And I would particularly point to the comment that Peter just made about the effects of vaccination and natural infection potentially being additive, in large part because we used to not say that, right? I mean, most our traditional virology training in medical school was if you had the natural infection, you got as much as you need, don't worry about anything else. This is different, so for sure, I would get the booster.
And then, of course, too, getting COVID is roulette, right? So if you want to play the natural immunity card, that's a little bit of roulette there. Like you don't know what could be a very severe way to acquire your immunity.
Okay, I have 2 questions. The first one is, could you just explain briefly again the difference between the binding antibodies and the neutralizing antibodies?
Sure.
And the second question is, for people with mitochondrial disease, do you have statistical data on, how many of them were admitted to the hospital versus, were sick for a day or 2 at home, or how many were down at home for a week, that type of thing?
Yeah, sure. So, okay, so to answer your first question, okay, so binding antibodies are basically antibodies that bind to the virus, to put it very simply. They actually stick to the virus, right, like Velcro, but they don't do anything to prevent that virus from being infective. The virus can still enter cells, it can still replicate. So the only thing that binding antibodies will tell you about is exposure. Were you actually exposed to that or not? Neutralizing antibodies, on the other hand, actually neutralize the infection. So in other words, they bind to specific areas on the virus that prevent it from entering the cell and replicating and making more virus. Is that clear? Okay. And then the second one is just with regards, it sounds like with clinical outcomes with regards to the mitochondrial disease patients. So we just submitted our paper, so it's not published yet. I told you about our small cohort, which is like 17 kids. 6 of them had, there were 6 hospitalizations, I think 3 ICU visits. Out of the total of 17, I think 6 hospitalizations, I think 8 got sick, right? So those other ones did well at home, they were fine, and they continue to be fine now, did not experience any problems. The only other study that's published is a study that appeared in the journal Neurology like 2 months ago, I think 2 or 3 months ago, which was done by a European group. But that was surveys. And I'm not discounting surveys, but that's how they did their study. They basically surveyed the mitochondrial disease population in Europe, and I think it was like 80 or 90 individuals, but it was a mix of adults and children. And mitochondrial disease in children is a different animal than adults. From a scientific standpoint, I kind of approach it with a little bit of caution because I don't think you can lump the 2 groups together. They found that, and I don't remember the numbers off the top of my head, but basically that the adults were having, versus the kids, were actually having more episodes of hospitalization, basically. But that's all I can remember from that study offhand. But I would say our paper, cross our fingers, it will get accepted. That would be out shortly, but then this paper is in Neurology. It might have been, the journal is called Neurology, and it's, if you just look up mitochondrial disease in COVID, it's the only paper that's going to show up. And that one is the one that said that adults tend to do worse than the kids with mitochondrial disease.
Thank you. I have 2 more virtual questions. This question I think is for you and both, Dr. Buckley. Have you seen any FEOD patients develop ADEM after COVID infection? And I've looked up ADEM just to tell everyone in the room what it is. It's acute disseminated encephalomyelitis.
I have not, no.
Okay.
I have not either.
Okay, so we have none. Okay, I just want to make sure our virtual folks feel like they're being heard.
And people, just so everyone knows, people usually contact me about this stuff. Not that I'm like the center of the universe at all, but people know what I do.
Right.
We have not heard any stories like that.
Okay, great, thank you. And the last question that came in virtually, how long after a COVID infection would you recommend an FEOD patient, or really a rare disease patient for that matter, get the booster after being infected?
I think the current guideline's like 90 days.
90 days?
Yeah.
They might have dropped it to 60.
To 60, yeah. I'm always cautious whenever I answer these questions because the guidelines kind of like, jump around a bit. So it's fluid. So I always go to the CDC website just to make sure my, whatever I say is correct.
Has there been any discussion about kind of like pre-treating FEOD patients before getting the booster to prevent?
Oh, like pre-medication.
To prevent rhabdo? And have you seen many cases?
Yeah, we used to do this at Mount Sinai. I think we've talked about this before. I think you've done this with your patients too with vaccinations where we sometimes would admit them and we would pre-medicate them and observe them for vaccinations. That is given that if they had like a history of some adverse reaction to vaccination or if I have to admit, even in situations if the parents were just overly concerned and we wanted to help them, get through that. Because for me, the end result of is what I wanted. In other words, that child would be protected. So.
Our immunologists have started cautioning our pediatricians that pre-treating patients with anti-inflammatory, so Tylenol, ibuprofen, naproxen, can decrease the efficacy of the vaccination. I think that falls into the category of is it 95% effective or is it 90% effective? You know, I don't think it is a huge issue, and as a result, I know that the fever and the increased catabolism are a risk factor. So I still tell my patients to go ahead and ignore whoever it is that's telling them don't pre-treat for the vaccine, and go ahead and do it. And if they're asked, just say they didn't do it so they don't get returned away and don't get the vaccine. You know, I hate to say it, but sometimes you have to just tweak the truth a little bit.
Well, it's funny that they're still saying that because the immunology community is kind of changing a little bit. Those two studies are actually pretty flawed studies. There's only 2 studies in kids where they actually did pre-treatment with it was either Tylenol or something like that, and looking at vaccination. They were kind of flawed studies, so I was surprised that the
Sometimes you just have to use common sense, and it's
risk
not,
benefit,
and it's not always common. The risk I know versus the theoretical effect that someone might have identified, and so I'm always gonna act on the risk I know.
I guess I'm kind of looking at it in hindsight at this point, given what Michael went through. Because he was fine pretty much from his first 2 shots. And then after his booster, he ended up in the hospital for 5 days with rhabdo and myocarditis. And it's like, is there anything that I could have done to make sure that didn't happen? Because
I think the answer to that is no. They're not really idiosyncratic reactions because they're
within the realm of
they're within the realm of what we see, and there's just not a good way of understanding why some people respond poorly to a vaccine and others just have no problems at all. And there's no rhyme or reason as to whether it's consistent across one individual. Now, I will say that in most cases, if you my experience is if you've not had a bad reaction the first time, it tends to be the same. So I've been very lucky with my COVID vaccines. I've just had a little bit of sore arm and get a fever. I mean, no systemic reactions at all, and that's been consistent across 4 different vaccines. In this setting, I don't think pre-treating with ibuprofen would have made any difference.